Welcome to the fifth hearing of the Committee's inquiry into the equity, accessibility and appropriate delivery of outpatient and community mental health care in New South Wales. I acknowledge the Widjabul people of the Bundjalung Nation, the traditional custodians of the lands on which we're meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander peoples joining us today. My name is Dr. Amanda Conn and I'm Chair of the Committee. I ask everyone in the room to please turn your mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Thank you again for being here today, and could I ask each of our witnesses, starting on my left, to state your name and position, and then take either the oath or the affirmation.
Certainly. Thank you for the invitation to attend today. My name's Kelly Bannister, and I'm the CEO of the Northern Rivers Women and Children's Services, which is based in Lismore, but we provide services across the Northern Rivers region, or as much as we have the capacity to do so. I'll take the affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. Thank you.
My name is Sonia and I am a trauma counsellor, qualified psychologist with the Worth team under Norworks, which is the Women's Outreach Trauma Health Service across flood-affected areas in the Northern Rivers. And I'd also like to say I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to start by making a short opening statement?
Yes, first of all I'd like to thank everyone for coming to the Northern Rivers and spending time in this beautiful region because I think it does definitely need a lot of attention, particularly post-flood. I'd also like to start off saying that I'm the psychologist with the Trauma Outreach Service, but I'd also would like to declare that I've been a case manager, mental health clinician with the Casino Carrigal Community Mental Health Service in the past, and the public health under Lismore LHD. Considering this inquiry is about community mental health services, I'd like to maybe point out some risks and barriers first and move on to some suggestions. First of all, coming from my personal experience and also still in the experience now in the professional capacity, I'm definitely noticing a distinct lack in service provision, unfortunately, and a very distinct lack of staffing across community mental health, particularly around in rural centres. I also know that the recruitment has definitely slowed down, particularly since COVID flood and fires, one in a row, and I don't believe that has changed an awful lot since, because it's very difficult to recruit people to the region post-flood. So there's a high reliance on temporary workforces, unfortunately, which then poses a risk to continuity of care, particularly with the trauma affected clients. Also, I'd like to point out that there is definitely a big splitting of services, unfortunately, with lots of different specialisations which are all really valuable, but unfortunately that does draw out specialists or your core services out into lots of different departments, which can then become unfortunately quite siloed, which can be confusing not only to clients but even to services in terms of referral. And speaking as a psychologist, I know there is quite limited psychology positions in those, largely held with a biomedical background, which unfortunately means that there's a big focus on biomedical services and medication and less on therapeutic intervention, which does undermine the recovery processes. So I'd also like to move on saying that something similar happens in the primary care service with, again, GPs being difficulty access in the region. and not being bulk billed, which then pushes it out to the NDIS providers. If people are eligible for any services. Moving on to being a women and children specific service, I would like to highlight that there is a big lack of awareness of coercive control patterns and domestic violence presentations, and what that means for mental health. There's a huge overlap in symptoms and signs and how that affects people, and a huge presentation of trauma has underlying relational traumatic incidents, which then presents as mental health, which unfortunately will not respond awfully well to medication. So really we are looking at better therapeutic interventions across the board. Similarly, with that siloing, alcohol and substance use will often be misdiagnosed as mental health and so on. So again, if departments could converge a bit better, then the misdiagnosis might be prevented. And transport, I'd like to say that transport is definitely very difficult to access here, which means rural and regional participants are often unable to access services, and telehealth, while it definitely works for a lot of people, doesn't work for people who don't have broadband or who don't have the funding to buy laptops and so on, or who can't actually who don't know how to use those services as well. Also, if you do have telehealth services, you might not see the full presentation, unfortunately. For people like eating disorders, you cannot gauge that as well. So what I'd like to see to improve those sort of services would be a really comprehensive induction, training, professional development across coercive control patterns, domestic violence awareness, and putting in some really specialised, specific assessment tools, making sure that it's not being misdiagnosed or left behind. There are real risks to domestic violence presentations, and I know in the service we've got the MRG tool, which is a really specific decision-making tool. Something like this could ideally easily develop for domestic violence also. I think that would be a really wonderful approach. Similarly, trauma awareness and trauma-sensitive care should be very, very important, and ideally merging some departments, or at least improving the communication across those departments. So yeah, I'd really like to see a fully integrated trauma-sensitive biopsychosocial model that very strongly incorporates alcohol and other substance use services and sees mental health presentations in a broader framework of domestic and family violence presentations. Thank you.
If I could just add on to
Absolutely.
the end of that, also an understanding of the impact of gender across all of those areas that Sonia's talked about as well, because it's different for different people and different strategies are required, and gender does play a significant role in how that shapes.
Thank you. Thank you so much for your evidence today, and also for all the work that you do every day supporting such a trauma-impacted community. We're very grateful. I've got a couple of questions, and we'll also go to questions from the other committee members. I was really interested in your comments around that fragmentation of the sort of social services and mental health sector. And we've heard evidence earlier in this inquiry from people with lived experience about some of the challenges navigating that system, that it can be quite overwhelming and complex, and sometimes put people off accessing care altogether. In your recommendations, you talked about improved communication, and I was hoping just to explore that further. Like, what would that practically look like if the state government were to try to lead a better process?
So I know some of those systems already incorporated that in different states. I believe in Queensland there is a more cohesive approach to domestic violence, for example, where you do have social workers, police and DCJ all sort of working alongside. I also know there's a similar service down in Victoria, I believe it's called the Orange Door, which provides services with, just a bit more having all those departments sitting together. Now, talking about Lismore, because that's where I'm from, I can see this working. I know they're very close geographically, but they don't necessarily share the same offices or the same meetings or things like that. So if those things could have really specific meeting times, or even have someone in there saying, like a domestic violence specialist on the mental health team, just so those departments start that communication. I think that would be a really beautiful approach, at least, or swapping around, having your tenures, 3 monthly tenures across different departments. Now, I'm talking from a really specific approach because I've come from the Casino Carrigal team, which is a very, very tiny team, and it's gotten tinier over the years. And those officers could, ideally could be shared a bit more, but often you don't even know if someone's downstairs for that given day or anything like that. So shared offices even could be a really team meetings. Yeah. Sorry, that's just
thank you.
Come with.
I also wanted to ask Ms. Bannister to expand a bit further on your comment about needing a more awareness of gender or gendered approach with mental health. Particularly, as you would be aware, there's a number of reports now coming out about the flood response and particularly the incredible strength and role of women in that response, but also the impact particularly on more vulnerable women in that aftermath of a disaster and a collective trauma like what's happened in the Northern Rivers.
Yes.
What should be done differently from a mental health perspective to care for women?
I think, again, it's about a more collaborative approach. It's about communication. It's about recognising the work that is done. You were referring to the floods, and there's a lot of women are still largely relied upon for the bulk of the caring responsibilities in communities, whether it's in response to the flood, whether it's mental health, etc. So there needs to be that understanding, and that they also then tend to neglect their own mental health needs because they're concerned about the children, the parents, the partner, and the rest of the community. I think there does need to be training around the different impacts of those circumstances, whether it's the flood, in the flood, and the different stereotyped roles that men and women tend to play or are recognised for, and the way that's viewed. It very much comes into play as well in terms of violence, domestic violence, and particularly in the coercive control area. There needs to be an understanding about that. So there really, in mental health, there does need to be deeper understanding and training around the impacts of gender and the implications of gender and gendered stereotypes. A specific area is an area that we're working on at the moment to develop up some pathways is around, just as one example, non-fatal strangulation, and which is an issue that is happening more and more, but it's not being diagnosed. And it's the same, and so we're looking at strengthening pathways and connecting up organisations to help with the treatment further down the line, because often it's misdiagnosed or it's not diagnosed at all. And it's a similar situation with mental health issues as well. Does that answer your question?
Absolutely.
Yeah.
And just one last question for me. You're obviously dealing with really serious issues day to day in your work, and I'm interested in sort of vicarious trauma and the way that it impacts service providers and health workers. Is there adequate support for the carers, or what do we need to be doing differently?
So when you're saying carers, do you mean service providers?
Yeah.
Yeah. Okay, well, every organisation handles that quite differently. I know that within our organisation we have certain debriefing and supervision practices in place, and wellbeing and employee assistance programs obviously are always very good. I know that Headspace Recovery to Resilience program has actually developed something very specific for that, even training workplaces in developing debriefing strategies to really deal with that vicarious trauma. I don't know what public health does at this point, but from my experience working there, I would definitely advocate for stronger supervision practices and making sure that they are accessible to all staff, whether they're in a centre or not. Similar with managerial and clinical oversight, and making sure that there's a regular check-in around that, because yes, a huge chunk of the workforce in Lismore and Northern Rivers has been flood affected privately, and they are going through these stresses for 2 years now alongside their work.
And there's a lot of, if I can just add to that, there is a lot of burnout, which I'm sure you're aware of in terms of the workers. And given it's a regional area, we have such a limited workforce, which Sonia alluded to earlier in her presentation. We're all drawing from the same workforce to try to deliver services. Workers are working in, say, part-time in 3 different organisations. That's quite common. It's a huge problem, and the point that Sonia made about it's different across all different organisations, whether it's government, whether it's community-based, I think having guidelines around best practice, around the sort of supports that work and that would be useful would be a really good thing. And I'm aware that Gender and Disaster Australia have been doing quite a bit of work in this space, and they're also looking to develop guidelines, and they going back to what I said before about having a gendered approach, that's very much embedded in their work, and they're doing quite a bit of work in this space in terms of being prepared for the next disaster, which is going to happen, and also trying to support areas that are currently significantly impacted. And that really takes an in-depth approach, but it also takes a broad approach in terms of across state, across the country, because I think we've been working with them to learn from our experiences in the Northern Rivers and how that might help people in other parts of New South Wales and the rest of the country. So I think that's looking to the places that are doing research and that are developing guidelines around this. There's quite a bit of work going on at the moment. So implementing some of them more broadly, I think, would be really useful, because then we're all on the same page. And I think it would really help in terms of the community, the support for the community, and for the people that are members of the community but are servicing that same community.
Thank you very much, and I'd be really interested to have a look at some of that research or reports if you're able to table it after the hearing.
Very happy to do that.
Thank you very much. Ms. Carter?
Thank you both for being here. If I can just, I suppose, continue the discussion in relation in particular to coercive control. And I suppose I'm interested, so Parliament's legislated with respect to coercive control. We expect those laws to come into force this year. I'm hoping that there's education with respect to the police. I'm just wondering whether you've seen any other community education or education about those laws, and who to contact, how they can be best used to support women, whether that sort of education's been rolled out across the community services sector.
I know that the legal centres are, at the forefront, and I know we have been sent communication. Unfortunately, the name eludes me, which has a very, very broad and in-depth explanation of the new legislation. So I know it's been rolled out across employers. I don't know how far it's gone community-wise though. I know that New South Wales is quite advertising it on different platforms. However, I've seen that not too much, it wasn't too detailed from what I've seen. So yeah, being very specific of what coercive control looks like might be very, very helpful to individuals.
Yeah, do you have any suggestions? Because, I mean, we can pass all the laws we like, but unless they're actually understood by the community and people understand what to do and where they can get support for these laws to be enforced. Have you got any suggestions as to who should be educated or what that should look like or how specific it might need to be?
As I say, I've been watching it, given our organisation, I've been watching the legislation and the development of it, and so knowledge that it's happening is there, but working within the women's sector, we still really don't have a clear idea about how it's going to be rolled out and implemented effectively, because as you say, you can change the law, but it doesn't necessarily change anything. I think the police are an obvious place where there needs to be much broader understanding and of what it looks like. And the implications. I've seen previously I worked in Tasmania and they had this stay-at-home legislation, and which the police, for example, were educated around, but it ended up backfiring, and both parties involved in the dispute were being arrested. And which wasn't the intention of the legislation. So I think we need to be very careful about how it's implemented, and the training needs to be not a 5-minute thing for the person that is the DV liaison within the police force. It needs to be much broader than that, particularly when you think of the percentage of incidences that the police are dealing with on a daily basis that involve domestic and family violence. It's a huge proportion of the workload, is my understanding. So I don't feel that it's enough to relegate it to someone who is considered the person that looks after that, because often in other circumstances you find, because there is such a demand, if you like, that person or those two people that have had the proper training often unavailable at the time when that knowledge is required. And it needs to be maintained, and it needs to be regular, not one of those, oh, well, we've done that training, and then we all know what it's like. You do some training and you think, oh yeah, that's great, and then time moves on and 2 weeks later you've forgotten because you've had 100 cases come in front of you. So I think that's important.
One last question, if I may.
Yes.
I'm just wondering if you have any insights. I think we're all familiar with the situation where domestic violence complaint is made and then at the time it comes to court, for a variety of reasons, it's withdrawn. Do you have any fears with your experience of coercive control, and given the nature of coercive control, that this will also be an issue around enforcement of coercive control, and are there steps that we can be taking, informed by your experience, to try and manage that?
Well, yeah, for one, it's seeing that it is a pattern approach. It's not coercive control, or what happens with domestic violence incidents. It's often seen as single incidents, and then you're talking assault versus assault, rather when you're looking at coercive control as a pattern-based approach. It's highly manipulative, highly structured and ongoing. As for training, I believe different departments in Queensland, they've all done the Safe and Together training, which means that different departments can communicate much more effectively with each other because they've all got the same language. So just, applying the same approach to all different departments is probably a really smart idea, because there's DCJ, health and police, they all overlap so much. So rather than seeing every single incident as an isolated thing, is really sort of having a very clear structure on how to approach it. So yeah, I would advocate for that training. I've taken it myself and I believe it's very valuable.
But to what extent do you think that training needs to be extended into the community sector, given they're the people who are most often encountering the women facing these situations?
Well, if we're talking about community mental health, ideally it would be community mental health workers. I mean, private sectors and NGOs, that's always, a great decision to make ideally, but you'd probably want to look for your, not necessarily managers per se, but you're looking for people that are very interested, that your forerunners. You get those people on board, and once they're on board, you can spread it a lot more easily.
Okay.
But it is essential that it's not just one body within the public service.
Yeah.
It's not.
Thanks, Chair. Thank you to you both for appearing today. I just wondered if I might continue along this sort of line of questioning and ask, in your view, do our state services provide care that is trauma-informed?
So, do you mind repeating that?
Do our state services provide care that is trauma-informed? And if not, what would that look like?
Yeah.
Can I clarify, ask to clarify, when you say state services, what are you including in that? Are you talking specifically about community mental health services?
Mental health services, yeah.
Okay, thank you.
I mean, it's a very contentious question. It is definitely incorporated into a lot of the frameworks and guidelines and so on. However, it does come to conflicts when you're looking at things like community treatment orders, or how people are being recruited into the service or discharged, how families are being involved. So I think at this current moment, some people are very, very good forerunners and they're doing everything they can. Unfortunately, that isn't the case for everyone though. And also, I think I'd like to take a step up from trauma-informed care to trauma-sensitive care. I think trauma-informed care is a very low bar, unfortunately, and I think it should definitely be raised a lot higher than that.
So what improvements could be made, in your view, particularly in the context of now crisis intervention, to make that more either trauma-informed or trauma-sensitive, as you say?
Diagnostics being one, probably that's a really important angle, is at the moment the way, again, if it's a biomedical model, you're very much looking at medication and medical interventions. So if you are stepping back a little bit from that and looking at, I guess, similar to coercive control and domestic violence, it's a presentation, it's easy to diagnose someone based on a single incident, but if you're looking at a very long-term presentation, you're probably going to be more likely to come up with something that doesn't fit neatly into your diagnostic categories. So I guess the whole, looking across a multiple systems approach will make it a lot more trauma-informed, because you're not looking at a single time that they're acutely unwell, you're looking at the presentation across a lifespan within families. So involving multiple families, family members or whoever is involved in their care in general in their intervention, I think would be very beneficial. Including multiple departments and maybe straying away a little bit from the medical only perspective and really incorporating therapeutic interventions more genuinely into the services.
You mentioned earlier the MRG tool, is that correct?
Yeah.
Is that something that you're able to either expand on or provide on notice to us, or either or? Yeah,
so MRG is the mandatory reporting guide at the moment. So if you have concerns around child safety, it's very easy to access online or through the existing systems. And it'll ask you a few questions. It's sort of like a flow chart where you go yes or no, and then it really gives you an idea to think about, well, what is the current acute risk? Is there an acute risk? What sort of risk factors are there? And depending on how you respond to this tool, it spits out a certain message. Okay, so this is a an appropriate referral service. This needs to be actioned straight away, and so on. So it gives you some very clear guidelines on how to respond to this specific scenario, and I can see that being quite helpful for domestic violence approach as well, because at the moment, front-facing staff don't always know how to refer someone on when they're in a DV relationship, for example.
Yeah, thanks. It's very helpful. Did you have, sorry, Ms. Bannister, did you have anything to add?
Oh, the thing that I was going to add that is a huge barrier, particularly in this region, but in the rural areas, is the workforce shortage, because we can talk about all of these issues, but if the workforce isn't there to deliver the service, it's a problem. If you can't fill the appropriate shifts with the appropriately trained staff, you have a problem, and it's dreadful in this area, the shortages around mental health workforce.
Thank you. Can I just ask you a couple? Thank you for being here, and thank you very much for the work you do for the women of our region. Can I just ask, are you currently, are you currently able to say, you said you service the Northern Rivers, are you able to say where across our region perhaps there is a concentration of demand? I know it's across the whole region, but is there a place in particular in your service area that you're seeing heightened requirements for your services?
If I can just say, I did say we service the Northern Rivers, but the reality is we're a relatively small organisation, so our footprint tends not to go into the southern area, the Grafton area. They're often serviced up from Coffs Harbour because we just don't have the capacity to do that. In recent times, it's really been those areas that were worst flood impacted. There's a huge demand. Would you?
Yeah, so like Kay said, there's definitely a big demand, and it's quite easy to fall into certain areas quite easily, and it's some areas are much easier to access as well as a service. And like I'm speaking from an outreach perspective, in collaboration with other services, when there is already services, it's quite easy to go and just add another program to something that's already present. However, the further west you go, the sparser it gets. So I would definitely say that the closer to the coast, usually the more accessible things are, even if there are a lot of transport issues, public transport and so on, or I would probably say west. The further west you go, the people aren't even requesting services because it's not even
on their radar.
They don't even think it's going to happen, if that makes sense.
It's very hidden, and that's a difficulty with delivering services. You've got this compound of issues where workforce shortages, no public transport, damaged roads and etc. in the aftermath of the flood, no services, particularly in the western areas. So it's very hard to know, to actually access the women when there's controlling behaviour going on. How do we even identify that they're there? They don't know about us, they don't have a way of accessing us. That's very challenging. Then you've also got areas on like the multiple occupancy properties is another area where I think there are a lot of hidden problems, and access out of the area and into services is very difficult, very challenging for them.
And just a similar question in terms of what you're noticing, and I'm specifically interested post-flood because that's the concentration, but is there a particular age of women, or is it across the board, or where are you seeing the sort of greatest need?
I would say that I've definitely noticed elderly women and older women becoming more and more susceptible to homelessness and not being able to access services. So definitely that's something I know we've engaged with fairly well in recent times, and younger women are very difficult to engage at times as well, especially with the rapid changes in housing. Families tend to be the ones that relocate the most frequently, from what I've noticed. So younger women are just displaced and then staying with friends or staying with friends or family. So again, not necessarily being very, not feeling confident in their help seeking.
Young women, I have strong concerns for young women in the community because there isn't a lot. They've been doing it very tough in the last couple of years, and I'm sure my colleagues that are going to be following this from Human Nature will be able to talk about this. There's very little service for them. Their schooling has been interrupted because they're floods, so they've may not only been displaced at home, but they've no longer had their familiar school to go to. If they're lucky, they've been relocated maybe at the university, etc. But I think with young people in that space, that's going to be an area where there's going to be a big growth in mental ill health.
And is that, I know when you, in your opening, you were talking about, the knowledge that there are going to be more disasters, more increasing, more frequent. Is that something you're seeing presented from young women, that kind of knowledge and that fear and that, as we refer to it more commonly, the climate anxiety? Is that something that is presenting to you?
Definitely. So it's not necessarily the primary presentation, but it's sort of an underlying change in attitude. But also I think I've also seen the flip side where a lot of young people know that it's going to happen anyway, so it's just something that they're really proactive about and engage with really readily. So I mean, you can sort of see both ends on it's just their daily life, and I think especially after COVID, there's been so many changes in such a short period of time. Some people just take it in their stride and become community leaders that way, and other people feel more and more isolated because during COVID they couldn't see their friends, and now after the floods a lot of people have moved. So it's just that it's almost like a permanent isolation. The biggest problem I've seen with people not just being able to not access services, but also just not being able to access community in all its levels.
And just finally, sorry, I know we're running out of time, but finally, an unrelated question, but the relationship, when you talked about the prevalence of coercive and domestic violence in amongst the people you're servicing, do you have a clear relationship with police and when you would refer something because it's criminal, or do you stay away from that kind of intervention and focus on the healing and the health and the safety of women?
We are not a crisis service, although we see women in crisis, and so we refer on to the appropriate service. The thing that makes it very challenging for us sometimes is the limited availability of the appropriate service, and then the response. I mean, anecdotally, there's stories that we could share, but the response from some of the mainstream services, if it's a specialist women's crisis service, they tend to know what they're doing, as you would expect. But when it comes to the more mainstream services, it can be a little bit hit and miss, and you can be concerned that the person is going to be more traumatised by that intervention than not.
Thank you.
And I definitely have seen a change in funding and staffing across different departments. So there's a bit of a handball sometimes. We've got availabilities, they've got availabilities, or sort of just, cross-referring and people moving from, public to NGO to private. So there's a lot of that sort of hand-pulling of clients across the region, which, is wonderful when specialists or professionals know each other, but it can be very... it can undermine a lot of the care because it's so fractured, and what we know about trauma is it's all about predictability, consistency, safety. So yeah, just I guess improving long-term care. At the moment, with the current existing community mental health services, they are definitely trying to cut them quite short, but what we know about trauma is we want to really provide safety long-term. So if that's something we could put in place, that'd be lovely.
Yeah, I think that really needs to be looked at, the sort of mandatory compressed time frame, and something done about that, that there is the capacity for more longer term. Yeah.
Thank you.
Thank you. Thank you so much again for your evidence today. The Secretariat will be in touch with you if there are any questions on notice. And for the awareness of people who are in the gallery and anyone who's watching online, we did have a last-minute change to the hearing schedule today. So we're going to take a pause now, but the next session will start at 1:30. Welcome back. Thank you so much for taking the time to give evidence today. Could each of you, starting from my left, please state your name and position title and take either the oath or the affirmation?
Trouble hearing you, sorry.
Oh, sorry. Do you need me to repeat myself? Can you hear me now?
Yeah.
Yeah, sorry. I just said welcome back and thank you for being here. And can each of you please state your name and position title and take either the oath or the affirmation?
Yeah, I'm Mr. Andrew Hamilton. I'm the founder and therapeutic lead of Human Nature Adventure Therapy and also a psychologist by trade. I'll take the affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given to me shall be the truth, the whole truth. Sorry, about to be given by me shall be the truth, the whole truth and nothing but the truth.
My name is Jennifer Park. I'm the Head of Operations at Human Nature Adventure Therapy, and I'll also take the affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to start by making a short opening statement?
I will. First of all, I'd just like to start by thanking you for this hearing taking place on the Widjabul lands of the Bundjalung Nation. Part of our submission to the inquiry was requesting a regional inquiry because there are very specific needs in terms of community access to community mental health services. So this is second best and we're very grateful to what it means is that a small not-for-profit like ours can actually attend face-to-face, so we're grateful for that opportunity. By way of introduction, I've worked for, I do hate to say it, but more than 30 years with some of our most vulnerable and disadvantaged young people. So that's involved working in youth homelessness and child protection, juvenile justice and survivors of sexual violence. Most of that, a large part of that time has been in senior management, and so both in federal and state government services and across the not-for-profit sector. What's led me to where I am today is unfortunately, most of those systems actually do not serve well the young people they exist to serve. And so I've had increasing frustration about being, witnessing and also being part of those systems that are actually not providing what it is the young people are actually quite clearly telling us that they need. Human Nature Adventure Therapy, we're a northern New South Wales based, not-for-profit. We exist to change the life trajectories of young people, 14 to 18-year-olds, who are experiencing really significant mental distress. So we know through many years of first-hand experience that with the right support, young people can overcome extraordinary adversity and thrive. We know that therapy works, but there's a great deal of evidence that will tell you that adolescents are the least likely group to seek help or to access professional care for mental health problems, and particularly those who are most vulnerable or at risk of poor outcomes. So at Human Nature, we occupy that enormous empty space between headspace and hospital called the missing middle, which I'm sure you've heard plenty about in this inquiry. It's a pretty lonely, large, empty space that we occupy there. So what we see is that medicalised model of the community adolescent mental health system means that these really highly evolved survival skills that young people have developed, particularly young people with complex trauma, makes accessing that office-based support impossibly challenging. The ability of a practitioner to develop therapeutic alliance with a client is really highly predictive of outcome. It's also really highly predictive of retention in therapy. So to strip that back, your relationship with your therapist is key to actually having any benefit from therapy at all, or actually bothering to being able to turn up for your second or subsequent appointments. So Human Nature has designed services that explicitly respond to the needs of regional young people. And those are young people struggling with mental health, behavioural difficulties and social exclusion. What we've done is we've combined highly individualised, clinically proven, evidence-based mentoring and therapy delivered through an assertive outreach model with fun and engaging activities in nature. And the fun and engaging isn't just because we think it's nice for young people to be outdoors. It's actually, again, absolutely based in evidence. And the evidence says that therapy delivered outdoors and moving is actually highly relevant for adolescents and is a really powerful engagement and relationship building tool in itself. We've got a multidisciplinary team of qualified mental health professionals and highly skilled mentors, and we work wherever young people feel safe and motivated to engage. So that might be in their homes or their schools, in a public space, in outdoor places. It's also very often in cars, actually, driving a young person to a headland, sitting on a headland, and all of the metaphors of the ocean that you can find for your mental health and to articulate your mental health are all kind of laid out there in that process. So we deliver a mix of one-on-one sessions, group activities and multi-day therapeutic expeditions and camps. And as I was saying, there's a really growing evidence base showing that outdoor therapeutic-based interventions, they're highly engaging and motivating, and really appropriate for the adolescent stage of development. There's recently published research on the quality of treatment for depression and anxiety disorders in Australia, and that has defined minimally adequate treatment for psychological therapy as 6 or more sessions. That's for adults. But using that definition, because I haven't been able to find research for adolescents, but using that definition, only 28% of Headspace clients received minimally adequate treatment for depression and anxiety. Almost half, so that's 45% of Headspace clients, received as few as 1 or 2 sessions, which was nowhere near the minimum. We supported 130 young people in 2022-23. 95% of those young people engaged in at least 10 sessions, in contrast with the statistics I was just providing for Headspace. And between 25 and 40% of those young people are First Nations young people. That's been without employing any Aboriginal staff until very recently. We now have 2 Aboriginal mentors. What we found is that without Aboriginal staff, young people still felt safe to choose a voluntary youth mental health service that wasn't an Aboriginal controlled service and didn't have Aboriginal staff. We did a very important piece of research employing an Aboriginal consultant to interview all of those Aboriginal young people and ask them what made them feel safe coming to us, what we did well, and of course what we could do better. And they spoke really powerfully about it's the quality of the relationship, that my psychologist got to know me, got to care about me. I actually got to know something about them as well. There was no prescribed limit to the number of sessions. They talked about being on country, being outdoors, feeling safe, which again goes to your trauma-informed question earlier. And of course they gave us really important feedback about what we weren't doing so well, and that's provided a really beautiful cultural safety framework for us going forward to ensure that we actually do centre their voices and their feedback to us. In amongst all that, the biggest challenge for us is sustainability. So we are currently operating without any government funding. We are entirely philanthropically funded. And yet we support some of the region's most vulnerable young people. We implore the committee to consider these invisible young people. They're those young people that are least likely to walk through the door of funded services such as Headspace, and yet they're most likely to be requiring more costly downstream interventions and facing tragic consequences, and to prioritise the resourcing of specialist services such as ours. Thank you.
Thank you very much both for taking the time to share your expertise and your experience with us today, but also for all of the wonderful work that you're doing.
Thank you.
It's valuable for us to hear about today.
Thank you. I do describe it as a labour of love.
I've got a couple of questions and then we'll go to questions from other committee members. My first question, in describing your sort of service delivery model, you used the term assertive outreach. We have heard that term earlier in this inquiry, but I was hoping you could just explain in detail what that means day to day in terms of how you interact with your patients and clients.
Absolutely. The outreach model is it's a really critical part of our service, and there is less and less of it being done. Most services have consider it too risky, too difficult to manage and too costly. What outreach means, as I said, is it means that we go to wherever we can maximise the capacity of a young person to engage with a service. And that will vary over time. The first visit is almost always at their home, and that's also an opportunity for us to start a relationship with their parent, which is obviously critical. It provides us with really valuable insight into what's going on in their lives, what that home environment looks like, what the relationship with the parent or carer is like, but also meeting them on their turf at a time and a place and a location that, as I said, it's about being trauma-informed. It's about creating that safety right from the beginning. And then the outreach kind of continues from there. For some young people, that also involves, a session might involve op shopping. So we are called adventure therapy, but for some young people, playing chess in their backyard with their psychologist is a big adventure, and we'll be doing that as well. So it's a really key part of our service. It's a really expensive part of our service. So it requires vehicles, it requires a whole suite of lone worker safety policies and procedures and frameworks, all of which we have in place. But it's the missing ingredient. I have to say, services will often sit in their offices and complain about young people who won't engage. And my response to that always is they can't engage. It's not their job to engage. It's our job to engage them.
Thank you. And just a follow-up question on that, in some of the evidence we received last year, the issue of the lone worker safety was described to the committee as a barrier to services engaging in, for example, home visits. Could you just let us know in a bit more detail what protocols you've got in place and if there have been any safety incidents for your staff?
Yeah, for sure. It's something we've done a lot of work on. We employed a contractor to produce, to really research the issue for us, but also to interview all of the staff one-on-one anonymously, so that each of them were able to give feedback about the aspects of the job where they did feel safe and where they didn't, and what improvements we needed to make. And also looking at the best practice evidence research around the world. There are a whole lot of lone workers, from vets and midwives to less and less, unfortunately, less and less frequently youth workers. So we've introduced things like all of the cars have satellite tracking. All of the staff have a personal safety duress app on their phones, which means we can track their location. It also means with a shake of a phone, they can make an immediate duress alarm to a 24/7 service. We have a whole range of training for staff in protective behaviours, dynamic risk assessments. We carry out that risk assessment of that first location, that first home, it's a really comprehensive risk assessment. And what we've learned is that on the whole, we can manage and mitigate risks. Once we identify them and we're front and centre about this is a potentially risky way of working, that the conversation shouldn't stop there, that there actually are a whole range of practices that can be put in place. And it's an ongoing, constant refreshing with staff. Sorry, there's a second part to your question.
Have there been
any incidents? We have incidents because we're working with young people who have complex trauma, and as I said, they've developed really heightened survival skills to get through life. I would say the incidences are of a lower nature and are not as frequent as the kind of common perception would be of a service like ours, and certainly have never been raised as an issue by our insurance, which is a very good litmus test. Yeah.
Thank you. And my last question is just in terms of the feedback you get from the young people that you engage, what impact does it have on them to have engaged with a service that isn't catered for young people?
Yeah.
Perhaps if I can start on that one. I think one of the key points is that, as Jen mentioned, many of the young people we work with have actually either found themselves unable or flat out refused to engage with conventional therapy in a clinical setting. And so for them, that may have been based on past experience of a school counsellor or another counsellor where they felt trust was betrayed, or they just were uncomfortable in that environment. It may be because of stigma, it may be because of their personal circumstances and anxieties. But I think I often like to say that what we do isn't rocket science. Youth workers in particular, there's a whole profession there that's been doing engagement of so-called disengaged youth really well for a long time. They don't necessarily have the clinical skills and the training to work in a trauma-informed way. And psychologists and social workers who we predominantly employ do, but they often don't get out of the clinical setting and for the most part don't. And so for me, there's just been such a massive gap in service. We started and built Human Nature from witnessing those young people falling through the gaps over many years, and often the young people who are most vulnerable and disadvantaged and most likely to end up in tragic and dire circumstances are the least likely to engage in those conventional approaches. So the feedback we get from young people is that they feel seen, they feel heard, they feel met. They're often as reluctant as ever to engage initially, and our team work really hard before they even meet with the young person to talk to family, to talk to people at school, to talk to the referrers, and have a really good sense of who they are and where they're at, and what's going to be safe for them, where they're going to feel most safe, who with. It might be that there's a welfare worker at the school that they connect really well with, so we'll go and meet with them in the welfare room at school as a first initial meeting because they don't feel comfortable at home. So whatever it takes, basically, and I think that's really felt by our young people. And we've been running, prior to the existence of human nature adventure therapy, one of our core programs, Recreate, has been running for over 15 years in the region. We've had probably around 300 young people go through that by now. And we run an alumni type program, a leadership and empowerment program called the Elevate program, where young people can remain engaged and mentor and provide peer supervision and support for other young people. So we're closely connected with them, and yeah, there's a lot of appreciation for that kind of support.
Thank you. Thanks, Chair. Thanks to you both for appearing today. I wanted to start by asking if you could tell us what is, and if there is a usual context in which people seek support from your service.
We've been, as Jen mentioned, we are almost entirely philanthropically funded and grants based, and as I mentioned, the drive for starting this organisation was for young people falling through the gaps. So we've been very deliberate about targeting our referral sources to those who are most likely to be working and to be able to identify those young people, and then we hone them down very carefully because we tend to do what it takes to work with them, and that can sometimes be a considerable amount of time when we're a relatively small service. Still, we want to make sure that the young people we are supporting are those most likely to need it. So those referrals will come from many from schools, school principals and heads of welfare and school counsellors, who can often identify a young person for whom they're pretty certain it's not going to end well. They're not there yet. We're really trying to work in the prevention space, but they can see they're heading for a bad place, and they've tried to get them to see the school counsellor. That's not happening. They've tried to get them to a boys group or a girls group. That may or may not have been successful, and then they're not engaging with schools. They're not going well, and so they'll identify them specifically, and parents increasingly are contacting us as we become more well known. And again, we have a pretty strong filtration process because there's a limited number of young people we can work with. The need is massive, and I guess that's something I really want to emphasise to you. I know you know that, but the need is massive, and it's massive in this region specifically. We speak about the floods, but nationally there's been a range of things, including COVID. For young people in this region, 2017 floods were huge, and so through that period of development, 2017 floods, the bushfires, the COVID lockdowns, and then our most recent floods means that their key stage of development has been severely affected by traumatic events. There's just such a great need for that level of service that is going to, I guess, find and support those young people who are most likely to end up in bad places.
Thank you. So in terms of the issues obviously has it grown over time, the need for your services, or is it, do you think as a result of more people becoming aware of your services? Is it one or the other, or both?
It's both.
Both, yeah.
I mean, Patrick McGorry talks a lot about Australia's, the mental health of Australians' youth is really declining, and it's a fairly global trend, and there's lots of research around what that might be. Social media and climate change would be right up there, and so I would say it's both of those things: growing demand and growing awareness.
And with someone that uses your services, is it usual for them to require that for a period of time? Are they needing to come back? What's the usual sort of, if there is a usual sort of entry and then the amount of time they might spend, with you receiving care?
There's certainly an average,
Yes.
and we deliberately don't have a set fixed amount of time, because if we can turn them around quicker, we'd like to move them on quicker, and we really are trying to move them on. One of the things we like to be able to do is to, I guess, season young people for conventional therapeutic approaches, because that's mostly what's available. We do want them to get to a place where they could go and get support from a headspace service and remain engaged, or a private psychologist, because we can't support everybody. Do you want to add to that?
Well, I guess this may come up later. We have a close working relationship with community adolescent mental health system, because again, often parents are, when it's a parent referring to us, often the young person's presented to hospital, there might have been a suicide attempt or a self-harm incident. They've come into that kind of very medicalised model, and the young person's been unable to engage with it, and so the parents are kind of, cast adrift and fairly desperate. What we've introduced fairly recently is a very intensive intake assessment process, primarily so that we have language to push back on that system, and to say that actually these young people we've assessed as too critical of need, their level of acuity is too serious for what we can hold as a small non-crisis, not-for-profit service. But I guess the other challenge for us is within that sort of 9 months average of how long we work with young people, they develop such a strong relationship with us and our way of working that it's actually very difficult for them to kind of then engage with a service structure that has a kind of statutory response to their level of need.
And of course, you're dealing with them at a time where they'd be transitioning from the child and adolescent system into the adult system of care, which are two very different systems of care also. In terms of that, so you say approximately an average of 9 months.
Yeah.
And then, I'm not going to use the term a discharge, but is it a sort of a tapering off process, but with an open door, or what's the...
Very much.
And have you seen, is there anything that would make it more effective, or...
Well, a part of our sort of exiting strategy is to, if that young person is requiring ongoing support, to provide warm referrals and take the time for them to properly engage with other support services. But also we will, have an open door policy to them, so that most of the time they live tumultuous lives, things happen, and they may be travelling quite well and then regress somewhat, and so they can come back and see someone they already know and reconnect with us there. The Elevate program I mentioned earlier provides an opportunity for a step-down type service where they can engage in some day program type activities, so adventurous activities that we conduct with peers and with our staff, so there's a way of them remaining connected over that time. Yeah.
Thank you. Ms. Higginson, thank you so much for being here and the incredible work you're doing for our young people. If you could get anything from government, what would it be? I know that, and just reflecting on the fact that you said you've already done some of this really hard and heavy lifting in terms of those protocols and working alone. What would you, if you could have anything from government, what would it be?
Multi-year funding.
Yeah.
It's the multi-year that's absolutely the trick. We received, for us, significant funding post-floods, but there were 2 one-year grants, so we increased our service delivery by 191%, but we were on a funding cliff at the end of that first year. So that multi-year funding will be key for us. I honestly believe that every regional centre in Australia would benefit from a human nature model. And so we've been doing a lot of work in terms of getting those kind of organisational infrastructure pieces in place, so that we can be in a position for Clarence or somewhere down in rural Victoria, I don't even know that area, Gippsland, I don't know, but an area where they can see they've got a growing population of young people with deteriorating mental health who cannot access these medicalised short-term models, for them to be able to say, we want a human nature, and for us to be able to say, well, this is what it looks like, and this is our kind of scaling up and out process, which is what we're really trying to focus on. But again, when we have to expend so much energy funding us to just open the doors, it gets in the way of the service delivery.
Right.
Yeah.
And so Sorry, go on, Andy, you were going to say something.
I think I'd just say more philosophically, I guess, a recognition that of this gap.
Yeah.
I feel like it's not recognised enough, and the degree of pressure that puts on the acute state-based services, and they're simply not able to cope. So there's often a revolving door that goes on with people with self-harm and suicide attempts, going into those services and then being pushed back out because they just don't have the capacity to support them. And so more upstream support from services like ours can have a massive impact on the stress and pressure of those services, those primary services. And also, I guess, more broadly, the intergenerational nature of what we're dealing with. And I think at some point we need to start really focusing on investment around interrupting those cycles of intergenerational trauma and disadvantage. And my feeling is that this is a really key place to do that, where it can be quite impactful. I started my career over 25 years I've been working in the mental health and criminal justice and drug and alcohol sector, and the reason I moved into working with adolescents was seeing adults in that sector who absolutely had those early signs within adolescence of things that were going wrong, and then the compounding trauma that happened since then from addiction, from behavioural stuff, from institutionalisation has made their situation so much worse. So the need to address these things at adolescence, and then working with adolescents and seeing how, as I said before, those most vulnerable are least likely to engage with what is on offer in terms of conventional clinical approaches, means that they're often invisible. They're not seen by the system, and particularly in this region where schools are in chaos post-floods, and many young people just haven't returned to school and aren't engaging with those services and aren't being seen, but they're absolutely there, and they're absolutely going to continue to have impacts as they become young adults and adults in both our systems and our society.
And can I just ask, in terms of the substantive kind of nature of the programs, when we, like human nature and the nature component, you refer to meeting young people in nature. Does nature itself, does the relationship with nature, as opposed to just sort of being in nature and having nature there as part of it, does nature itself, in terms of the human interaction with it, the way we manage it, the politicisation of the environment, is that a component or is that not?
I'd say two things about that. One is that the evidence is increasingly clear of the positive impacts on well-being of exposure to nature, immersion in nature, connection with nature. So that's one of the, I guess, what I say a positive side effect of our work, as is physical exercise, fresh air, sun, nutrition, connection to others. All these things are so good for mental health and have really strong evidence base. At the same time, it was brought up earlier about what's commonly referred to as climate anxiety, and in my experience, almost all young people are in some state of that, and seriously concerned about their future, and those young people who are already vulnerable, who may have experienced complex trauma and disadvantage, are even more impacted by that, and a relationship with nature can be an antidote to that. And particularly positive climate action as well.
Yeah, and just finally, last one. Okay, last one. This is what we do, we get in trouble. And so in terms of just the geography, and I may have missed this and I apologise if I did, the geography of where you are and where you're finding the most sort of presentation across the Northern Rivers, is that something that you can share?
Sure. So we're based in Ballina, and we work with young people across Tweed local government area, Tweed, Byron, Ballina local government area, and then because of the size of our service and the recent limitations to funding, with the flood funding ending, we've had to restrict our services, so we can only provide now service to Lismore, not to Nimbin, and to Evans Head, not to Coracai. And I'd be saying they're two areas with high need, as the previous people who talked about the further west you get, Kyogle and Casino. But where I would say even within that strip that we cover, and it is a coastal strip, but there's still very high levels of need. And within that area we're covering almost all of the pod villages, and we have young people who are living in those villages, and all of the uncertainty that's created. So I mean, I would say, yes, Lismore and Mullumbimby is where we're seeing really that kind of heightened, persistent trauma symptoms as a result of the flood in particular. But in terms of young people's general health, I would be saying across the region that young people are really struggling. Yeah.
Thank you.
Thank you. I can see that you've got a pile of documents next to you. Is that something that you'd like to table?
Our recent impact report, just recently published, so yeah, if we could table that.
Thank you very much. Thank you so much again for all the work that you're doing and for sharing your experiences with us today. And the Secretariat will be in touch if there's any questions on notice.
Great.
Thanks very much.
Thank you.
Thank you.
Beginning of your testimony, the Chair will ask you to take an oath on affirmation to tell the truth, an oath with the Bible, affirmation without. Do you have a preference?
Could you say that again?
Yep, so at the beginning, the Chair's going to ask you to
I think I'm born
those are the words that you want to read out. It's a little bit wordy if you want to have a quick look at that.
Kids in this region and grandkids and kids that have had to...
Welcome. Thank you so much, Ms Jackson, our next witness.
Please call me Faye.
Thank you for taking the time to share your evidence with us today. Could you please state your name and title and take either the oath or the affirmation?
Yes, my name is Faye Jackson. I'm the inaugural Deputy Commissioner with the New South Wales Mental Health Commission. However, I'm no longer a Deputy Commissioner. I'm currently in a position of General Manager of Inclusion with a very large not-for-profit specialist mental health service that is in many areas of New South Wales, Queensland, South Australia, Victoria. However, funding hasn't been available for us to move into this area. I live here though, and I'm a member of this, committed member of this community, and community is often all we've got here. So, I'd like to acknowledge the traditional custodians of this land, this beautiful nation that we're on, Bundjalung Nation, and pay my respects to elders past, present and emerging, and promise to walk gently on this land while I have the privilege to live here and raise my children and grandchildren here. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. If you like, you can continue with your opening statement.
It's actually a little bit difficult for me to hear you.
Sorry. I'll lean forward.
Okay.
Would you like to make an opening statement?
I suppose my opening statement would be probably that the way I will present, what I'll present to you may be very different to anything else that you hear. I am very passionate, as everybody is that works in mental health, or should be, but I will be speaking to you more from a lived experience perspective of being consumer. I don't use that word though anymore gloriously because I've managed to break those ties. I am a person with lived experience of severe mental health issues. I've been incarcerated by the mental health services, treated against my will. I'm a carer though also of children and grandchildren who have mental health issues, and I've worked as an advocate for the last 27 years in public system, then in the commission, and now in the not-for-profit sector. So I have these documents that I'd like to table or give to you now that you might want to look on. There's a lot of information there that you won't want to go through now, but just to say that really Northern Rivers is a hothouse example of what all regional and rural areas are experiencing across New South Wales, well, across Australia. And although we would be considered rural or regional, because of public transport and the lack of services here, we're really remote, in my opinion. So there's such a huge difference between what's available in the city and what's available in areas such as where we live here. However, having said that, what's available in the city, according to the productivity review, the Royal Commissions, etc., are broken services anyway. And those are the actual words that are being used, broken services. So advocates have been saying that for, two and a half decades. However, it seems as though it's falling on deaf ears. It can no longer fall on deaf ears. We now here have the highest rate of suicide. I'm sure you've already heard this today, in Australia. However, I really believe that we are just an example of what's to come for other areas. We can't continue trying to get services that aren't there or services that don't fit the need of anybody. And they're not only not fitting the need of people who need the services, they're not fitting the needs of staff either. So the staff are getting exhausted and mental health issues because of the models that they're working in. As a Deputy Commissioner, I had the great pleasure of going to many services across New South Wales, Australia and also internationally. In New South Wales, all of the public services are operating under the same policies, the same protocols, yet the culture within those services are very different. The cultures in services that value the voice of lived experience and peer work are far more healing for all people who access those services. I was the lead writer of a chapter. I was invited to write a chapter for the Australian Handbook of Rural and Remote very remote, I think it is, mental health services. And I wrote that with a number of people. One of them was a director of nursing at Goulburn Base Hospital. I asked her to review all of their episodes of seclusion and restraint. She looked back over an 18-month period, and what she found was there was no episodes of seclusion and restraint when a very well-trained, very experienced peer worker was on duty. None. People with lived experience, supporting people with lived experience. We are hope. We are hope personified in front of them. We talk with each other. We have a way of connecting that is almost immediate. We know peer work works. We look at AA, NA, Nursing Mothers Association, gardening clubs, whatever. Peer work works. However, it seems as though we have to keep on saying and producing more and more and more and more research showing the same things about the quality and value of peer work to people with lived experience of mental health issues. So I really beseech you, please, really open your hearts, open your minds, and know, because we know that the services are broken, that we have to produce services a different way. Flourish Australia, who I work for, we have a peer-operated service in Hervey Bay in Queensland. That peer-operated service has not had a single suicide in the whole time that it has been operating. The Wide Bay Public Mental Health didn't want to work with our peer workers, first of all. They were frightened of them. You know, everybody that's crazy is dangerous, ridiculous kind of attitude, with no factual background for saying that kind of thing. So it took us a while to get them to work with our peer workers. After only about a year, I received a phone call from the head psychiatrist there, the intake officer, saying that their whole service had changed because of the way our peer work service was supporting the public system. So the doctor told me that what they would do is a person would come into A&E. Of course, A&E isn't the place for people who are in psychological distress. There needs to be a standalone peer-run service that people can go to on the hospital grounds or in the community, preferably, first of all, so that they don't even get to the point of needing to go to a hospital grounds for anything. Go there and then be diverted away from hospital into these community peer-operated services. He was saying that he rings our staff speak to the person on the phone, ask their permission to come and see them. They then drive whatever time of day or night. They go and they meet with the person. There's a magic that happens between people that have lived experience. There's a shorthand and a spiritual connection between people almost immediately. Our peer workers start with saying, I'm a peer worker. The people ask what that means. They explain what a peer worker is, and that is about we purposefully use our lived experience to connect with you and support you and build hope that you will be okay, that your life can change. There is a better life ahead for you. And they purposefully give small amounts of their story to connect with the people so that the people know that the person that they're talking to hears and understands them without judgment or any kind of persecution. The person then goes with the people back to our service, and they, unfortunately, we lost, although like so many services that have proven that what they do is wonderful, we lost funding for the respite house that we had. But we were able to take people into the respite house and have supports for them there 24/7. Now people are just coming to our day service, and our staff go out to their homes and support them in their homes. But the psychiatrist has told me that they've gone out to our service and seen how the people are supported there, and are seeing that people within a very short time are getting jobs, going to TAFE, going to university, they're being citizens. They're not being the mentally ill. They're being citizens. And in rural and regional areas in particular, everybody needs to pull their weight. I grew up on a farm in a rural area, not this area, but you know when you live in a rural area that everybody must pull their weight. We saw that during the floods. If it weren't for each of us as a community member supporting our neighbours, supporting the people close by, hundreds more people would have died. People who were responding to their voices that they hear, were working beside people who are school teachers and nurses and ex-army, digging, trying to get people safe, trying to get people out of the water, trying to save people's lives and clear up the mess afterwards. If people with lived experience can do that in that kind of almost Armageddon kind of situation, then what more can we do if we're given the chance? In the documents that I've given you, you will see there that there is lots of proof, data showing, research showing that peer work works. Peer-operated services are in the community are a way for people to be able to go there without fear. You've just heard that many of the kids, many young people, won't engage with the public, the clinical public services. That's not just kids. That's people across all ages. Survivors of mental health services, we talk about us being survivors, not of the mental illness, but of the services, of the systems, because we experience heterogenic harm through the services. We go into a service, we may be coping, we may be just scraping through, we may be just managing to keep our jobs and pay our mortgage and do all that. But we've experienced trauma very often in our childhood, like these poor kids around here have. They will have terrible mental health in the future if we don't act now. But they have experienced, most people, 52%, you'll see there in the 52% of women who have had domestic violence, who have come out of domestic violence, get a diagnosis of mental health issues after they've experienced domestic violence. That's just one example of trauma. Around 87% of people who have been sexually abused as children, as I was, have a diagnosis. Diagnosis in the long run doesn't help. What diagnosis does is let the community and the perpetrators off. It says that the problem is in you. You're broken. You're ill. We're not. We're having a normal range of responses to trauma. Yet normal trauma responses are being pathologised, and then we're often forcibly treated against our will, and that can go on for years. I have the great honour of being able to move to this area where there was a broader acceptance of people with odd ideas of just being normal. And I'm no longer on community treatment orders. I'm no longer being scheduled. I'm no longer on enforced treatment, because the attitude of the community here was acceptance and love. We need services to be like that. Non-judgmental, field-coming services full of love. And that's what peer work does. We love the people that we're talking to. There's an automatic, we sit down beside them and we're with them, and we do have love. A peer worker lovingly challenged me and changed my life with one very short conversation. I was crying because I'd been diagnosed, another diagnosis, one of the serious and enduring type. I'm a voice hearer. I also experience extreme anxiety and panic attacks and depression and all the rest that goes along with that. I was crying, and this peer worker came to see me. She asked me why I was crying, and I said, because of the diagnosis that they gave me, and because they also said when they delivered that diagnosis, they also said, you need to change what you expect out of life, because you won't be able to hold long-term relationships. You won't be able to work, and you won't be a valuable member of your community. That was the actual condemning words that I heard. I've heard those words, not very, very similar, not just from one, but from several psychiatrists. The biomedical model is a deficits-based model rather than strengths-based. That peer worker lovingly challenged me. And she said to me, Faye, I have that same diagnosis as you, but I work, I pay tax, I pay my mortgage, I support my family, and I'm really active in my community. If I do that, why can't you? And then she lovingly challenged me one step further, and she said to me, in fact, Faye, what gives you the right not to? And my life changed then. I stopped seeing myself as a victim and started seeing what I could do, started looking for what I could do still with this diagnosis. At that point in time, I still accepted the biomedical model of mental illness. I no longer accept that, not just for me, but across the board. There is just so much evidence that trauma is what causes these. Yet, there is only one specialised trauma service that I know of in New South Wales, which is in Thirroul. It's a women's service. It's amazing. They demedicalise people. They take them off their medications. They tell them that the response that you're experiencing from the trauma that you've had is legitimate and real, and of course you would have that kind of response. And people start to heal. That's the kind of service that we need. Yet it's a private service that could only attract funding for one public bed out of the whole of New South Wales, when we know that 87% at least of the people who have diagnosis have had trauma. This isn't, you just heard before, it's not rocket science. It isn't. It's about providing the services that advocates have been asking for 25 years. It's about not just listening to the people, the so-called experts. We know who those two men mainly are, who love to hear their names like that, on radio. I have great respect for those two men. However, I no longer have respect for services that cause trauma when they're supposed to be healing. They're causing trauma to the people who are already traumatised. They're diagnosing them and taking away hope. People are stuck on these medications, and then our physical health starts to decline. I'm not shaking because I'm nervous, and I'm only shaking the amount that you can see today because I have the privilege of being able to afford prescription oils to try to stop the neurological disorder that I gathered from having enforced psychiatric treatment through the medications, lithium, epilim, etc. Now you know my diagnosis was bipolar schizoaffective disorder. I didn't expect to live till I was older. Our people like me on the kinds of medications that we're parked on have a shortened life expectancy of between 15 and 27 years, depending on what research you read. If a peer worker was in hospitals and they were causing trauma to people, they were causing them physical harm, they were causing their thyroids, their livers, their kidneys to fail. They were causing them to put on 20, 30 kilos of weight. That was leading to diabetes and heart failure. They were causing them to be disabled because of the side effects, unwanted side effects of how they were treating them. They were alienating them. They were giving them a diagnosis that was alienating them from their family and community. Would the government continue to fund peer workers to do that? I don't think so. Yet we continue down this biomedical model of treatment that is causing physical harm, trauma to everybody involved in it. Well, I shouldn't say everybody. Yes, every now and again there is a person who gets help.
I'm so sorry to have to interrupt you.
Sure.
The evidence you're giving us is extraordinarily valuable for our work. We've only got 5 minutes left, and I did want to give the opportunity for committee members to ask you some questions.
Yes, I apologise for...
That's all right. My first one, you've obviously covered a huge range of issues. Early on you mentioned the need for alternatives to emergency departments for a significant number of people. This afternoon the committee is doing a site visit to the Safe Haven here in Lismore.
Yes.
And I was interested in your perspective on the Safe Haven model and how well that's working.
I think Safe, like Headspace and everything, the different Safe Haven models can have different cultures within those as well, you know. So, but I think that's a far better way than people going to an emergency A&E where they're told very often that they're a waste of time and a waste of space because the A&E staff have to treat people with real problems, real health issues. So I think that's really helpful to have that. However, I do think that we do need services, peer-operated services in the community before even that starts. We need prevention and early intervention isn't just for young people. I need prevention and early intervention. I've had this diagnosis since I was a child. Well, it's changed, but depends on which wheelbarrow that doctor's pushing. But I've had mental health issues since I was a child. And now I'm 63, but I still need prevention and early intervention. I don't ever want to, I will never go back into hospital. I can't do it. I won't survive it. I won't. We can't cause this to other people. It must stop. I'm just one butt. I'm just the example. Thank you. I laugh a lot too, you know. I'm just the example of thousands of people. What's happening to thousands of people every day. I have to get early intervention if I start to get rocky. I need to be able to just walk in a service without being afraid to go to a hospital. I won't go back to a hospital. I need to be able to find that service in the middle of town where I can walk in, see friendly, welcoming faces who will put an arm around me, come, take me, sit beside me, ask me what's happening for me, ask me what's going on, and say, no wonder you're feeling like that, darling. We can help you. That's what peer-operated services do. They heal right from the first conversation, and that's what we need to be doing. You will see in the documents that I've given you pyramids of care, models of care that I believe will work far better because of what I've seen in other countries and because of what I've seen in Australia as well in peer-operated services. We can do far better for far less money. For every $1, we found, there's been research done on it, on returns of investment, every dollar invested into a peer-operated service returns a $3.27 return on that investment. There's no clinical service able to do that. We need to be offering that peer support first, and then clinical service is last, and then seclusion restraint should never be there. The Mental Health Act must need to be changed. We have laws to protect people if there's violence or whatever. We can use those laws without engaging the Mental Health Act. The Mental Health Act strips away our human rights.
I think Ms. Bell had a question for you.
Just a quick one. In the pyramid of care, which I was just looking at briefly, thank you for your evidence
putting together this document and the work you've done.
You mentioned open dialogue at the
yes.
top, which I was quite interested in. Could you explain more for the committee a bit about what that is and why
Yes.
that's right at the top, because it's right at the top.
Yeah. Well, Aboriginal people would say that that it's actually just what they've been doing for decades, which is everybody sits around and talks and tries to find a way to support people and solve issues. But the official open dialogue model came out of Finland. I've been there, I've seen it operating, and it's beautiful. So it's in keeping with the nothing about me without me that people with lived experience say. So, it is, I guess, what peer-centred services should be. At Flourish Australia, we talk about peer-led services because in most people's experience in Australia, peer-centred services means the person sits in the middle and the clinical services sit around them telling them what they will and won't do, who they are and who they won't be able to be, where they will live, what they will take, what they won't take, what they'll do. In the open dialogue, they sit there with the person, and if it's a young person, with the person's teacher, with the person's parents, with the person's friend, with the clinicians, with the psychologist, and they all talk together, working through with the person leading what they need. The young person, the older person, whatever, talking about what they need. And then they come to an agreement of what will be done to support the person to get back into school or get back at work, and so it's nothing about me without me. Don't make any decisions about me, don't talk about me without me being there, that I can answer your questions or say, no, your assumption is incorrect that you're making about me. That's what open dialogue is. There is also another form of open dialogue that you may hear about that, but that's more of a one-to-one, and that's a peer-run support. It's volunteer, where we teach people with lived experience of hearing voices to communicate, have an open dialogue with their voices and get to the basis of why their voices are carrying on. So it's just getting down to the nitty-gritty of it all. So, yeah.
Thank you.
And it heals. It really heals people. I know multiple, large numbers of people who are healing from psychosis without medications. I no longer take psychiatric medications. I don't need them because I've had healing through peer support.
Thank you. I'm so sorry that we've run out of time. We could probably discuss the issues that you've raised all day. And I did want to just briefly reassure you we've had no questions for you about the clinic in Thirroul because we're hearing from Dr. Karen Williams, who runs that service, on Thursday at our next hearing in Sydney.
That's fantastic.
Thank you so much.
If you can't convince the government to provide peer-operated services everywhere, then please convince them to provide services like that one, but also to fund peers sitting within them as equal partners in the support and treatment of each person that they'll be supporting and treating.
Can I ask, I know time's up, where was the house that you said lost its funding?
Harvey Bay.
Thank you.
In Queensland, yeah.
I know.
That was a quick one.
Yes.
The Secretariat will be in touch with you with any questions on notice, and thank you so much again for taking the time to put this document together and share with us your experience and your expertise.
Thank you. I made all that document and intended to refer to it, but typical of me, I didn't really follow to the script. But I think perhaps that's an indication of that services can't either follow scripts that the biomedical model has written. We need to follow the script of the individual person and their individual needs, no matter what their age, what their religion, what their gender, what their culture. Thank you.
Welcome. Thank you so much for taking the time to give evidence today. Could you please start by stating your name and your position and take either the oath or the affirmation?
Yeah, my name's Rob Curry. I'm Executive Officer with North Coast Allied Health Association, and my affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Would you like to start by making a short opening statement?
I will.
Would you like to start by making an opening statement?
Yes, please, thanks. So firstly, I'd like to acknowledge, I live out the back of Wauchope, so the North Coast Allied Health Association covers the same footprint as the primary health network, so it's from near Port Macquarie up to Tweed, obviously including the Northern Rivers. So I feel a bit crumpled, sorry, I've driven a fair way this morning. Do I look crumpled?
No, not at all. You look fantastic. You do.
So I've driven through Biripi country and Dunghutti country and Goombanga country. I'm here now in Bundjalung country, and it's beautiful. It's looking stunning at the moment. So it was a long drive, but a pleasurable drive. It looks great, the country. I acknowledge all those traditional owners. I'd like to also quickly acknowledge the previous speakers. So I heard the headspace, or part of that conversation, which I found very interesting and is relevant for my association in many ways, and also the peer worker compelling engagement with you folks. And I'm a health professional, so I apologise for that. I support peer workers. It's a really a key part of what we need in the mental health space, as well as any professionals. I'm a physio by background. I'm getting a bit older. I don't practice anymore, so I do things like a little bit of land, bush regeneration, and my 12-hour-a-week role with the North Coast Allied Health Association. Spent most of my working life up in the Northern Territory, mainly in Aboriginal health. Came down here about 10 years ago. My association represents allied health professionals in the field. Not all members are allied health professionals. There are some allies who are supportive of the allied health people. But they're in the field right across the region, and they're 20 different allied health professions or more. You know that, don't you? The allied health professional space is complex, and it's many professions. It typically is tertiary trained health professionals as a broad definition. Not doctors, not nurses is a negative way of putting it, but that's who we are. So we have some key issues around mental health that we're concerned about. I hear about these principally through our people in the field, our practitioners in the field. So the main ones in the mental health space are social workers and psychologists and counsellors in the allied health space, but it also includes speech therapists and occupational therapists, physios, sometimes exercise physiologists, others who come into significant engagement with people with mental health in the field, if that makes sense. So the core people are obviously the psychologists and social workers and counsellors. So we have a number of issues that we're concerned about. One is just the general lack of mental health workforce in rural areas, including on the north coast of New South Wales. You again would know that. Institute of Health and Welfare and previously Health Workforce Australia describe in great detail the relative lack of mental health workforce in these regions. So I'm sure you're aware of that. Limited access to child mental health services. This is a key for us. Now, I heard the headspace discussion and we share a lot of the points raised there, but it's for us, the key area of lack at the moment is for kids under 12s and their families. There's a shocking lack of services for that group. Everyone knows this. This is not unknown to anybody who lives in the community as far as I can tell. And also it's pre-Headspace. So Headspace is an organised response to people with mental health, young people with mental health problems. But prior to that, there is not an organised response to mental health. So families just battle it out, and obviously I'm saying families because parents are in it up to their ears with their kids. So the kids are manifesting mental health issues or difficulties. You need to work with the family, with the parents and with the kids, and the services just aren't there. Now in this area, there's a program called Resilient Kids, which through the PHN, which is just starting out. So that might start to really help in that space. But fundamentally, around Australia, and particularly in this area, and particularly around the Coffs Harbour area, actually, there's just a really long waiting lists to see mental health practitioners. So in this area, there are high rates of medication, psychotropic medication for kids. And that's simply because the GPs don't have anyone to refer to. So they have little option but to use medication. And it's also an early intervention space. If you can work on families and kids or support them, then you prevent chronicity, or you hope to prevent chronic lifetime problems with mental health challenges. So it's logical to invest in that space. It's not there at the moment. We can give you data about the long waiting lists, etc., to see people. Our other issues are mental health care for older people. It's not well organised, it's under-resourced. The Royal Commission made recommendations to the states around that issue. We want to see more training for all health providers in trauma-affected care, not just mental health professionals, but for everybody, because trauma is such a common theme or a common issue in the community. Mental health services for the Aboriginal community, so here we can say something like, look, it's a Commonwealth responsibility and we can wipe our hands. It's not a state responsibility, it's a Commonwealth responsibility. I reckon that is indicative of one of our biggest problems. Our services are not integrated. If you look at this town, between the not-for-profit sector, the private sector and the government sector, there's hardly any communication in the field. There must be linkages made there on behalf of families. And also, if there's not enough private practitioners, for example, meeting needs, I would expect New South Wales Health, for example, to lobby for those private services, because if they don't, it all comes back to the ED department and hospitals and New South Wales services. So it's all connected, but we're not making the connections. And that was my final point, really. It was about the need for integrated care in local communities. We have a community here. All of the workforce should in some way be linking productively with other parts of the workforce. So I'm happy to talk about any of those issues in detail, or we have suggested a number of potential solutions in our paper, but I won't talk about those. I'll throw to you guys to ask questions if you have them. First thing I want you to know is who I represent, and that we're arm's length. Our organisation is not so much about the allied health professionals. We want to make sure there's good access to allied health services, and those services are of quality. And the way we seek to do that is through supporting allied health professionals, if that makes sense. So we're not a professional association like the Physio Association or the AMA. That's not what we do. Over to you guys. Thanks. Yeah.
Thank you so much for the detailed written submission that you've prepared, as well as the time to give evidence today. I have a couple of questions. The first one, I suppose, in the context of the workforce shortage, and we've already heard evidence to this inquiry about the rates of burnout for health professionals. In your submission, you talked about the need for more clinical supervision or debriefing. In practice, what could that look like? How does it work? Do you think we need to have more clinicians in the region who can provide that support to your members, or is it something that could be provided externally? How do you think it would work in practice?
So who should provide? That's a good question, but I think New South Wales Health can lead on that. It's hard for the private sector to lead on it. There's no coordinating body of private allied health professionals anywhere in Australia, really. I'm not saying it's the Wild West, but practitioners work by themselves. They're not supported the way GPs are. The federal government has not fully acknowledged its relationship and responsibilities around the provision of allied health services. So we can't get, even though people do organise themselves in the private space for CPD, etc., I think it's going to be entities like mine, North Coast, they're sort of voluntary entities, representative entities, and people like New South Wales Health that will have to lead on this, or the PHN offer good quality trauma-informed care training for all health professionals. People are crying out for. We've run a couple of sessions. We linked with Mission Phoenix Australia, who are experts there in Melbourne, and to help us deliver CPD on that. But I'm talking about training here, some decent quality training for all health professionals engaged with the public.
Thanks. I was also interested in your submission. You talked about the recent recommendation around outreach for older people, but also visiting school settings for younger people, and I think there has been a real theme within the evidence we're receiving about meeting people where they're at rather than asking people to come into a clinical space. What do you think are the current barriers to that outreach happening, and how do we address them?
Well, I think in schools is, talking about the under 12s, the kids that are just, and families that are not getting adequate support at the moment, it would be a great place to invest, to have some mental health resources, human resources in that space, so that teachers then can engage with professionals and peer workers and support workers and pick up that slack. But it also means that they can then engage with the private sector. So they might, if I was a part-time psychologist in a school, for example, and there's a counsel there, I might say, well, I think you need an intensive course of therapy, so refer to the private sector under Medicare. That can be done. Or the issues can be resolved pretty much in school if the teachers have that professional support from psychologists. So I think investment in some core resources in the schools, and particularly in primary schools, would be of enormous benefit. Do you think that? I think it's logical, isn't it? For some reason, we haven't gone down that path.
I'll get into trouble if I let you ask the questions, I think.
Well, I won't say that you nodded.
That's all right. You can hear what I think once we finish the inquiry.
No, but my point again, though, is that it just seems logical that you would invest there, and it would be a great space, too, for families to engage, not just with private practitioners, but in a community sort of space. Yeah.
Thank you. Mrs. Cotter?
Thank you. Thank you for your time. I'm interested, a number of people have discussed workforce issues. They seem quite acute in this area, but they seem to be present in other areas as well. From the perspective of your members, do you have any insights why there is difficulty, for example, attracting sufficient psychologists to the North Coast? Is it money? Is it lack of professional development opportunities? Is it nobody wants to live on the glorious North Coast? What are some of the drivers that prevent an adequate workforce?
Well, traditionally, it is hard to get health professionals out of the cities. We all know that. But we have a particularly attractive area. So if I was wanting to work in child psychology, for example, it's very difficult for me to make have an adequate income under Medicare to treat the child, because I need to work with the parents as well on the school. So the current funding mechanism is not supportive of that practice. So people avoid it, but rather see adults because it's more straightforward and more cost effective for their business to do that. Does that make sense? Were you aware of that?
I'm asking you the questions to try and find out.
So in other words, there's a structural problem in the current Medicare system, nothing to do with the states in particular. It's to do with the federal funding. But in terms of recruitment locally, I think each region can do a lot to recruit people. And for me, it would be stuff like setting up communities of practice that invite people into the space, setting up good quality training for counsellors and psychologists in this area that would invite people.
Is that a role that your organisation could be involved in, given that you gather together allied health practitioners?
Yeah, well, we're only a small organisation, so we lack capacity. I tell people we've got somewhere between 100 and 1 million members, which is not true, but it's closer to 100 but yeah, we would like to get into that space, but we don't currently have the capacity. Yeah.
And can I just ask you a question about peer workers? And we've heard a lot of comment about peer workers. Do you have any views about whether there's, if you like, a one-size-fits-all? Is somebody with lived experience of one type of mental health issue able to be a peer support worker for somebody with any type of mental health issue?
I wouldn't personally have the expertise to comment on that, except to say that we think peer workers are a key part of the picture, as the other lady explained. You know, that it's not just health professionals. I'm here advocating for health professionals, and people need that. They need that expert advice, but that's only part of the picture, as is psychiatric services. But peer workers have to be a key part of making this whole area work, I think, really human accessible part of it.
And in terms of making it work, what's your observation of children and adolescents and families? Are the families brought in as part of the greater whole to work with the child and the adolescent, or are they kept at arm's length?
At the moment, there's very limited resource for parents, but you could envisage that you could do work with parents as a separate theme.
Yeah, I guess I'm asking you, do you perceive that that's happening at the moment, or is that an area that we could look at developing?
It's an area that needs to be developed. There is a GP in the Coffs Harbour area who voluntarily does parental training and support at night after her general practice, but that's volunteer. There's no sort of funding for it.
Thank you.
Much needed though, yeah.
Thank you. Mr. Val.
Thanks, Chair. I just wanted to ask you quickly, you mentioned you've got somewhere between 100 and 1 million members. Are you able to tell the committee how many members?
Yeah, we started in about 2015 and we have about 140 members.
140?
Yeah. And they're not all mental health, they're speech therapists.
That was my next question, yes. So how many would you say, because you mentioned social work and psychology as being the predominant allied health workforce in mental health, how many would you say are working in mental health currently?
Probably 20 odd. 20. So most of our members are physios and OTs and speech and exercise physiologists, etc. Some of them work in the mental health space, but they're not core mental health workers like the psychologists are.
Any dietitians?
Yes, plenty. Yeah.
And what would you say the role is, or what would your members say the role is for dietitians in the mental health space?
Well, I think, again, I'm probably not expert to respond to that, but to say that obviously many people with mental health challenges have dietary issues as well and can be supported in that way as they can by exercise physiologists with exercise, etc. Probably the evidence is not direct there, but it's certainly an important aspect of their overall healthcare.
Thank you. That's all right.
Can I just mention something about the Aboriginal situation, if I can? I mentioned at the beginning saying that it's like they're two separate worlds in terms of meeting that need, but it would be great to see additional allied health provision or access to the Aboriginal health services in the region. They have very limited access to psychologists, physios, OTs, etc. It's expected that the Commonwealth will fund that, but where they don't or haven't, there's a gap, and we're not filling the gap. So in our local community where Aboriginal people live, that need is not being met, even though there's an expectation that the Commonwealth will meet that need. So it would be great if, this one I'm talking about integrated care, if the Commonwealth and the states or New South Wales came closer together to resolve that issue. So they need services that are culturally safe. So AMSs like to draw, say, a psychologist into their service, into their practice, their way of doing business, in order to deliver that service, rather than clients going out to private practice spaces or whatever. So that would be a huge thing for the Aboriginal community if the AMSs had more access to contract or even put bums on seats, get allied health people into their practices. It would make a big difference, I think, in terms of access. Does that make sense?
Yeah. I had another question from your written submission.
Yeah.
You talked about this idea of a collaborative allied health practice, and we have had previous evidence about the PHN collaborative GP practices.
Yeah.
What would the nuts and bolts of that look like? How would a collaborative allied health practice work?
Well, we think it could work. So with GP practice, they have traditionally had a lot of support from the Commonwealth through divisions of general practice and PHNs, etc. Their principal focus have been supporting general practice. We would like to see the Commonwealth, through the PHNs, support allied health practice in a much deeper way, so those services can combine better and deliver better access to the public. For example, we'd like to see digital health supported in those allied health practices. So there's very little digital communication of health or communicating health between doctors and allied health professionals in hospitals is still very awkward despite my health record, etc. We'd like to see investment, bringing allied health into that space so the patient doesn't have to keep saying what's happened, It's there in the medical record. The doctor and the allied health professional and the hospital are communicating efficiently the way we should be in 2024. That's not happening, and that investment hasn't been made. I don't know what New South Wales Health can do about that, but it certainly needs to happen, I think.
Thanks. Ms Higginson, did you have any questions?
No, I'm very happy, thank you, with the evidence. Thank you.
Okay.
Thank you. I don't think there are further questions. Thank you again so much for your detailed written submission and your time and the long drive that you've made to share your experience with us today.
Thank you. The process has been interesting. It was good to hear the other speakers as well.
Thank you. And the Secretariat will be in touch with any questions on notice.
Can I take my affirmation?
We can email your name tag. People do like us.
Mr Orchard, for being with us today. Would you, just for the record, state your name and organisation?
Sure, thank you very much for having me. My name is Joel Orchard and I represent Wardell Core, which is the Wardell Community Organised Resilience Effort.
Great, thank you. I believe you have the words in front of you. Would you like to take the oath or the affirmation, please?
Sure. So I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. And did you have a short opening statement?
Sure. I think firstly, I really appreciate the opportunity to come and discuss a little bit about our experience. I represent a very new community organisation that was founded in direct response to the recent flooding event. Wardell is a very small community on the very lower part of the Richmond River. So by circumstance, we saw all of the floodwaters from the rest of the Northern Rivers go past our small town. We have established essentially an informal neighbourhood centre. We exist in a vacuum of support services in a rural area with no real direct access to other support services. And effectively we've become a one-stop shop providing, the full gamut of community support, social support services, disaster recovery support, links to all of the government formal and informal support and recovery services, and predominantly focused on community health and wellbeing. We've relocated to an independent building and we've established ourselves now in the community to try and provide a full and complete wraparound support service. We continue to provide crisis management, links to case management and RSS. We've got our own internal dedicated mental health support service with 6 days a week of counselling available to the community free of charge through a grant tender through Healthy North Coast. And then with a range of other grants and other support programs, we've been able to offer quite a complex and comprehensive support service. Everything from therapeutic horticulture to social eating opportunities to peer support, training for community members. Food relief is a really big part of what we offer now as well. And increasingly we're seeing, I guess, the compounding impacts of the disaster with the cost of living crisis having cascading effects on people's mental health, and then I guess the exacerbation of preconditions of things like domestic violence. The rates of presentation, even in the past 12 months, in difference to the first 12 months, have escalated substantially. Homelessness and housing insecurity is clearly having a massive impact on the health and wellbeing of people. So, I guess we're trying to provide a very place-based solution and by the book with recommendations from all levels of government around the benefits of the bespoke opportunities that community-led recovery organisations can offer, and really sort of look to integrate our community into their own recovery best practice to be better prepared for future disasters. And I think sort of offer something that's very relevant to the people of our region.
Okay, thank you. If I may start, and then other members, I'm interested in in your name, in the fact that you've got resilience, if you like, at the core of your name. Could you perhaps just sort of give us a couple of observations about the relationship between resilience and mental health?
Sure. I mean, I think initially, and our own organisation has had to evolve. That's been a natural process. It was very unclear in the beginnings how long the different aspects of recovery would take. But what was very clear from the outset, due to the scale and nature of the disaster, that it was not going to be a short-term fix. Resilience to us is represented by the immediacy, and although we're not a combat agency by any extent, we are still a recovery agency. And resilience, I guess, is the growth and development of people's own abilities to recover and then to fortify themselves for future events. It's very clear to us from our place and geography that we're in a region of very high risk to future severe weather events, and I think it's been well documented that we're at extreme risk of riverine flooding, extreme risk of ocean rising, extreme risk of future severe storms. So ensuring that our community is well prepared now with their own mental health and well-being to withstand what could potentially be another impactful disaster even in the next 12 months. And then, I guess, future-proofing, by integrating youth voices into our mission and hearing, I guess, from the local community what they feel will better prepare them for the future.
Okay, thank you. Thanks, Ms. Carter. Thanks, Chair. Thank you, Joel, for appearing. Sorry, I hope it's right for me to call you Joel, for appearing today and for all the work that you do on an ongoing basis. I wonder if you could explain to the committee what is the usual context within which people seek support from your service, and also whether this has changed over time.
Thank you. I guess there's a few facets to the question. When we analyse some pretty basic but raw data, so we capture on presentation every person that walks through the door, roughly where they're from, why they've come to visit us, and what support services we've been able to provide. We have seen some changes in that over time. We, I guess, are fortunate in that because we're an informal service that has stepped into this space, we've been able to define our own parameters around who we support and what resources we've got to provide, but we've never put geographic limits on the services that we offer, whereas in difference to some of the other support services around, they've had to limit it either by postcode or geography or for whatever reason, that's where their funding is limited. We have focused, I guess, on our immediate community, but an extension from Broadwater, which is the next village upriver, all the way through to Ballina and Ballina inclusive, which has put a huge burden on our very small team and very under-resourced organisation to cater for a really large geography and a very large population. I think it's worth pointing out that the Ballina LGA is the only shire in the Northern Rivers without a neighbourhood centre, so we've filled, in a sense, that gap as well. We've had to, by demand, cater for a large population of the West Ballina community that don't have their own dedicated community flood recovery support service, and so we get people that will transit out to Wardell to access help and support. We're inclusive of, I guess, the Cabotry Island community, which is a large population of people that have been completely displaced. And Broadwater itself is a village just about the same size as Wardell that doesn't have any continuity of care at all. So by geography, we cater for a large area. There's a number of small rural centres plus a large rural area, so we're catering for a lot of people, within the cane farming community as well. In terms of the demographics of those people as well, our mental health service doesn't cater for under 16-year-olds. That's outside of our scope, but we do cater for family support, which includes children. We provide, through some youth support funding, some dedicated youth programs, and that's a way we can integrate communities' needs and the children's needs and then provide better pathways of referrals onto dedicated youth support services. So in that way, we are sort of a first line or a first point of contact for a lot of people. what I really value about the way we've designed our service is that it's holistic and it's vertically integrated. So somebody might present simply for some company, and we know that social isolation and loneliness is having massive impacts on people's health and horrendously exacerbated by this disaster. And in fact, a lot of people are just now starting to present for the first time, so have taken this amount of time to feel comfortable venturing out of the home or venturing into the community to access help and support and company. So we can greet them at the front door, we can refer them to peer support and a cup of tea. In that moment, we can identify if there's any other critical needs that they may have, provide immediate referrals to case management, to financial counselling, to domestic violence services, or book them an appointment with a counsellor. We can also register them for Tai Chi or a Qigong class or a meditation program that we have every week, or into a number of the other social connection activities that we have. And then by the time they've left, 1 or 2 hours later, they've got a parcel of food and a whole range of appointments. So I think the ability for us to integrate all of that in one place has been so dynamically successful for the community that we support. That I honestly couldn't see a better way of doing it at this stage, at the scale that we're at.
So you're essentially sounds like a hub.
But absolutely a hub, yeah.
I wonder if you have any data or could perhaps comment on whether you have seen a change over time in what services people are presenting for, particularly with cost of living issues, whether they're it was first just for a cuppa, now there's more need for food or clothing or things like that.
Yeah, we do have data, and I can absolutely follow up with a report that can give you the date by date data that we've got every quarter, and we presented an annual report, and we can now compare, I guess this year, the data we're starting to gather from presentations versus last year. Anecdotally, it's very clear that people are now spending a lot more time when they come to visit than they had in the past. I think the urgency of need initially meant that we had really high numbers of throughput of clients accessing things quite quickly. It was grab what they need and get on with it. So I think the aspect of social connection now is becoming more and more important. We're now probably seeing more presentations of a different form of crisis. So initially it was flood recovery crisis. Everyone had their own kind of crisis. But now we're seeing more systemic challenges that are presenting as more complex cases of crises. So we see people now presenting with a whole gamut of challenges rather than it just be targeted at flood recovery. They might have initially come in because they were desperate for clothing, food and towels. Those were easy solutions we could offer. Now it's people coming in who are homeless or having extreme levels of housing insecurity, most certainly financially insecure or destitute, are presenting with domestic violence and severe post-traumatic stress disorder symptoms as well. Those are very difficult clients for us to cater for. Excuse me. And we're most certainly seeing a much higher increase of rates of suicide and suicidality, which is a really difficult thing for essentially a team of volunteers to cater for. We're really fortunate to have extraordinary staff in our mental health team who are, at 6 days a week, completely overwhelmed. They're working well beyond their scope, and we're constantly having to check on their health in order to be able to manage the caseloads. And in part, that's because of the extreme need for them to cater for everything in-house. There's literally nowhere for us to refer clients to at the moment. And in many cases, all of us, myself included, and the other staff that provide informal case management will take on a load of responsibility to support those clients, because it's much more productive for us to manage in-house than to send them on to a service that may or may not contact them in a relevant period of time. We've had people literally lose it. I mean, I don't know how better to describe that, just because they're sitting on call waiting for a support service, and they can do that in our comfort with company, but that impact on people who are already at the breaking point of their mental health is extreme. So trying to monitor that carefully, compassionately, professionally, within a very complex community environment, especially where people are constantly engaging with their friends and neighbours. There's no anonymity within that environment. We're certainly able to provide professional discretion, and people have privacy with the clinic rooms, and there's privacy with entries and exits, so we're able to cater for that. But in part, I think also the fact that it feels like a second home to so many people, that we've broken through a lot of the stigma to accessing those sort of support services as well, that people feel really comfortable to be quite raw in their experience, which in some ways you would say is a beautiful gift, that people have come a very long way to being able to express themselves. It's deeply healing for everyone. I know it's a roundabout way of answering a question, but I think to paint the picture of the spectrum of what we're dealing with, and I think
same people over and over, or is it different?
It very, very much a spectrum. And yeah, to that point, we have quite a lot of people that really need the continuity, and we have a lot of people still presenting for very first time. There's a lot of very stoic people who have felt deeply uncomfortable about accessing support and services, that have had to take a very long time to come and ask for it. And unfortunately, in a lot of cases, they have reached a breaking point with their finances, their life and lifestyle, access to work or inability to work before they're coming asking for help, and they're then more difficult to support. But I think the feedback that we get from the community is that the value of having a place that feels so comfortable that they can then access things that they would never have dreamed of, including just general food relief or a mental health counsellor, has meant the barriers to them accessing that help are much lower. So,
Thank you. Thank you, Joel, for everything you're doing. I kind of watched the journey of CORE, and it's been quite amazing, really. So thank you to you and your teams for bringing that journey all the way from day one, really, of the flood crisis. I just wanted to ask if there was something that government could do for CORE. What would it be? What would your priority wish be for government to do in the immediate?
I mean, I could give a long list, but I think to prioritise, I think it was very clear to everyone the scale of this disaster was going to demand quite an extensive recovery. Very early on, there was no concrete language to describe the duration of recovery that was meaningful to people. And I think being able to articulate that to the community and the public and all of the support services early on would have helped link that to resourcing that was genuinely necessary over a sensible period of time. All service providers that I'm aware of are constantly staring down the end of a funding cliff, knowing that there's nowhere to send clients if you run out of funding, and we're included in that. We were very fortunate to get a 2-year funding from the beginnings, which felt like such a long lifeline, but realistically what everybody needs is 5 years of continuous funding with an exit plan. So we need transitionary support. As a community support service that's very new, we're very aware of grant dependency and how challenging that can be, and we're really interested in looking at establishing ourselves as an ongoing support model that can use social enterprise or create other forms of revenue to sustain our services, so we're not dependent on government funding, but that needs resourcing and support in itself. I think from my reading that all levels of government document that it's the role of government to enable communities to lead their own recovery. That seems to be very well written and researched, and yet not very well delivered. And I think as a community recovery support service that's trying to lead by that example, we feel very unsupported in many ways by government, certainly not enabled to do what we're clearly very good at doing. I think the impact that we've created speaks for itself. But I'm not sure that the frameworks that government has to enable communities to do that work themselves are being acted on. So I think there's definitely a space for someone to look at why that barrier is between language and actualising. I think it was also really important to note that when we established, we went looking for models, for case studies, for research around how communities can do what we've done. And there isn't a roadmap or a template or a very clear pathway or even a third party or external community agency like a peak body to support these kinds of organisations' development. And I think that's a really critical missing piece, specifically in New South Wales. We lent heavily on the Tasmanian Neighbourhood House Association, who were so supportive, very forthcoming with all manner of practice development and governance frameworks and all of the kinds of pieces of paperwork that you need to establish, which is so hard to manage when you're in the midst of a disaster, but we got there. South Australia have some really great research, and in Victoria, following the bushfires, there's some really great detailed reports. There seems to be nothing in New South Wales, and I think that that's a massive gap that could be pretty quickly solved simply by talking to the organisations through this disaster that have been successful in creating meaningful and useful programs. So I think documenting the success stories, analysing what's working well and why would help other communities in other areas to more rapidly move into spaces where they can offer better, more competent community support. I imagine those are the three things I'd probably put forward. Yeah.
And just, you mentioned about Cabo and Cabotree Island. What's the relationship that CORE has with the First Nations community there?
I would love to say that we had more resources to be more effective in that relationship. It's been a priority for us to have a very open door policy to supporting Indigenous members from the community, to try and demonstrate cultural sensitivity to their needs. At this stage, we don't have specific Indigenous liaison or any kind of program to support that community. I think fortunately for them, they've maintained quite a comprehensive support program themselves through the Uniting Support Service that's coordinating the village. And I think in many ways the Cabotree Island community has been always empowered to look at working with their own community to develop their own support, which is a good outcome for them. And bit by bit, we're looking at ways that we can create more activities, especially through youth and children, where there's just better things for the kids to do. And we find when we put on youth activities, definitely we get more engagement from that community. I mean, we're just up the road, so it's easy for us to drop in and have a chat with the elders there to see if there's things that they need. We share resources, and we have discussed running a number of programs on their site or on ways to get them more involved. I think it's been a little bit of a rush just to do the stuff at the level of intensity that's been needed to really concentrate on deepening that relationship, which was clearly quite fragmented before the flood. And I think that there's a lot of work to be done in providing a much more safe environment for the Indigenous members of our community in Wardell.
Thank you.
Just another question, if I may. And look, this is me thinking aloud, if you'll excuse this. We've heard some different examples of the hub model that I think you've got a very interesting example of that you've established in Wardell. In a sense, in terms of government service, New South Wales was really set up to be a hub for government services. Do you see any synergy, or would there be any benefit to what you're trying to do if, for example, I don't know, a day, a fortnight or something, Service New South Wales could co-locate with you to help people navigate through some of those Service New South Wales activities?
Yeah, I mean, Service New South Wales had remote delivery early on.
Yep.
The accessibility to that support, I think, disappeared or evaporated from the Wardell community far too quickly. There was limited public transport options for people to get to Ballina to the service centre, where that's still available and ongoing. And clearly the flood impacted people's ability to transport themselves, and there was a lot of loss of vehicles and things like that. So transport's definitely been a barrier. The reconstruction authorities probably became the more relevant group from the state agencies for people that needed to access that help. And then with a lot of the confusion that sort of evolved around the buybacks and retrofitting and things like that. I mean, there's a lot of confusion in our community that hasn't really seen that funding trickle down the river far enough. And at a point, I guess, people just resigned to the fact that it wasn't going to happen, and they've now started to look at how to recover their homes independently. So we've seen a transition. I mean, I think Service New South Wales probably would have been much more effective to work in better partnership with us. They always felt quite as an aside. At a point, they positioned themselves in a different building, so community members had to sort of go between the two for different offerings. We clearly could have accommodated them in our building, and I think having a better relationship with Service New South Wales at that time would have been much more effective for everyone. I'm not sure why it felt like there was a separation between what we were offering and Service New South Wales were offering. I mean, not specifically to Service New South Wales, but there was certainly an issue with all of the government services early on that we just saw just this revolving door of new faces and new people, and it was very confusing to us and to everyone who to talk to about what. It's been a high priority to us to provide continuity of care, and unfortunately I think the high turnover of staff, or for whatever reason, government services have completely the opposite effect. And what we know clearly is that anyone who has to repeat their story and rewalk their trauma history time and time again entrenches that challenge, and it distances them and disenfranchises them from accessing those formal and traditional support services. I mean, I had a very fortunate opportunity to work in northeast Victoria after the bushfires, and it was very apparent how important continuity of care was so that people didn't get re-traumatised, and we've provided that with what we offer at the community hub, and that seemed quite at odds with what was available through government services. So I think that could certainly be identified as a challenge for people.
Thank you. Thanks, Chair. You mentioned earlier in your evidence that Ballina doesn't have a neighbourhood centre. I don't know if you can comment on why that is the case, or if there is indeed a need for one.
I would say there's absolutely a need for one. I would argue there was definitely a need for one before the flood.
Okay.
I mean, based on a wide range of demographic evidence from, an ageing population and lifestyle disease and socioeconomics. My understanding historically was that there was a form of neighbourhood centre in Ballina, and I'm not entirely sure of the history of why that dissolved, but there's been a large period of time where there's been a substantial gap. I think there's a lot of complementary services providing what parts of a neighbourhood centre would offer, but the fact that they're distributed and they're not embedded in the community like a neighbourhood centre is why there's now a need to look at resourcing one. I have tried to stimulate conversations through our local member Tamara Smith about how we can look at solving that as a problem, and I think there's definitely an appetite and interest from the community at large to look at that issue. And I'm hopeful perhaps in some ways that what we're doing in Wardell will be a catalyst for a more formal neighbourhood centre that can provide those support services in Ballina. Wardell's interesting in its placement in that we're right on the edge of our local government electorate, our state government, federal electorate, and in the boundary of the Mid-Richmond Neighbourhood Centre, which is based out of Evans, and so we're kind of not really a focus or within the catchment of anything. So I mean, in that ways we've provided what we can in the space where we are, but now the evidence is very clear that Ballina has sort of missed out, and the residents of Ballina who are still struggling with home recovery, given that they're in a larger city with what you would consider better access to services, are still having an extremely difficult time with their recovery, especially when compared to Lismore, which has quite a large gamut of support services available to them, even though they're overwhelmed as well.
And just, I suppose, a follow-on question, is there a role for neighbourhood centres in that community mental health space? And would you have the sort of postcode data which would suggest where people have come from to access your services, and if that has changed over time and your catchment has grown?
Yeah, not postcode specific, but I guess by suburb definition. Yeah, so we have that data for sure. We can see that over time. I wouldn't, from my understanding of the data, I don't think it's an extreme shift. The areas which I've been accessing the help are reasonably consistent over time. I mean, I think from our latest data, it's just over 50% are from Wardell, and then the rest of the 50% are split from Ballina all the way through to Broadwater and all of the little urban, rural areas in between. I think, I mean, in terms of a neighbourhood centre, from seeing the results of the impact that neighbourhood centres widely have provided through the disaster recovery, and my relationship to the neighbourhood centres from Wollumbar, Kingscliff, Evans Head, Mullumbimby, and even over this way in the Community Gateway, like there's a really clear examples of how impactful those kinds of organisations have been able to rapidly generate the right kinds of help for people. And I think there's really good evidence to say that neighbourhood centres are really functional aspects of community-led disaster recovery and really ought to be considered for future disaster planning as a more integrated component of disaster recovery and resourced accordingly, rather than, I guess, what's seen at the moment, which is they just have to pitch for what grants are available and hope that they're best equipped to, you know, access that resource.
Thank you. Thanks, Jen.
Got one last question. Wardell Core is obviously an example of the benefits of a community-led approach to providing a mental health service. So I appreciate the irony of my question, but which do you think are the parts of that service that might be replicable in other areas?
I mean, I think probably the best part about it is the holistic nature of it rather than the individual parts. I think the greatest impact that we're having on people's health and well-being is the fact that we can offer all those things in one place which is comfortable, you know, which feels organic. I mean, the difference between us is not a clinical environment. There's no uniforms. People come in. We exist in an old bank building. It feels like a home. There's couches. It's very easy for people to access. That in itself, I think, is widely replicable. It's also scalable. I think what we're offering would be just as relevant at a larger scale as it would be to a smaller scale. The fact that it's owned and led by the community itself, so we're an incorporated association. All of our board, our staff, our volunteers are all local people. Almost essentially all of them have been affected by the flood themselves or are still in various stages of their own recovery. And our association's membership exists of about 300 of our local community members. So that gives us the ability to discuss with the people that benefit from the service the most about exactly what it is that they need, and we're able to reflect that in the way that we deliver services. So I think it's not so much the aspects of what we offer that have the greatest benefits to other communities, but it's the system that we've created, which I don't think is particularly novel, but it works very well for what we're doing and could easily be replicable elsewhere. I'm personally very interested in looking at blueprinting what we've done so that we can handle that as a very simplified document onto other communities wherever who may be impacted by this similar kind of incident, so that they don't have to go through the rapid learning that we've had to go through and butt their heads against all of the challenges and barriers, because there's simple things that we put in place early on which have had dramatic impacts on our ability to be successful, and simple things like incorporating means that we could open a bank account, which means that we could apply for grant funding, which means that we could have our own public liability insurance, which means that we could lease a building. Whereas compared to other community organisations that have required auspice agreements or have been informal for long periods of time, haven't been able to access those simple building blocks which have enabled us to then become a much more comprehensive organisation even at this point, which is still quite short term. We've become a registered charity very, very quickly. We've got great accountability. We've got all of the checks and balances in place to be, an organisation that could have existed now for 10 years, but we've done that in a very short period of time. And I think with support, community organisations could get to where we've got in even a more compressed timeline, which obviously has huge benefits to the people that need that help. And arguably, I think for your perspective, saves government an enormous amount of money. We are a very lean operation and have had huge impact, and had government had to invest in government wages to do what we've done, would have been at magnitudes of cost much higher. So this is cost saving for everybody.
Thank you. Thanks so much for your time today to share your experiences with us, and also for all the work that you're doing.
Thank you very much. I really appreciate the opportunity. Thank you.
Thank you. And the Secretary will be in touch if there's any questions on those.
Thank you. Legend. Thanks, Joel.